So good evening, everyone, and good afternoon, good morning, depending on where you are joining from. Welcome to our Fireside chat for today. It's going to be series number 205, and we are having two exciting topics today. The first topic is on PrAKI overview, and this will be handled by Dr. Kate Bramham. The second topic is on consortium activity, which will be taken through by Katherine Clark. So it's quite, I'm sure it will be a very enlightening discussion as we're listening in. So I'll just briefly introduce our speakers, but before I do that, my name is Dr. Yuri, and I'll be the moderator for this session. Kindly type your questions or reactions in the chat box when needed, and I'll read them out to the speakers at the end of the session. But you can also use the raise hand feature in case you want to answer your question live, and I'll give you permission to speak. So our guest speakers for this talk, Dr. Kate Bramham is a consultant nephrologist at King's College Hospital and a reader in nephrology and maternal medicine at King's College London. Her clinical and research focus is kidney disease in pregnancy, with a track record of service development and multidisciplinary research across nephrology and obstetric medicine. She co-leads initiatives improving recognition and management of pregnancy-associated AKI, with a strong emphasis on practical, scalable change in real services. The second speaker will be Katherine Clark, who is a specialist midwife and a researcher at King's College London, whose portfolio centers on practical solutions for hypertension and renal disorders in pregnancy, supported by a Kidney Research UK Stonygate Allied Health Professional Doctoral Fellowship. Her research explores point-of-care diagnostics and remote monitoring of cardiovascular and related biomarkers to optimize women's health. Katherine works closely with nephrologists, obstetricians, frontline maternity teams to co-design screening pathways, minimum datasets, and training resources that can be implemented and audited in routine care. Her approach blends implementation science with day-to-day service realities, helping teams adopt new practices while maintaining governance and data quality. So over to you, Dr. Kate Bramham. I believe you should be the first speaker, if I'm not mistaken.
Fantastic. Thank you so much, and thank you for that kind introduction. I'm so delighted that this talk is happening, and very honoured to be your 205th presenter. Hopefully you'll be able to see my slides. Is that coming through? So the first thing I think I want to share with you is that we are really trying to change the dynamic and the narrative around pregnancy associated acute kidney injury. And a new term has been coined, which is PrAKI, so AKI, but with the PR in front of it for pregnancy. Pregnancy associated rather than related, because there are lots of things that could be happening to the kidneys which are not necessarily pregnancy caused by pregnancy. For example, infection or drug-related kind of complications. So it's been a kind of a long journey in terms of defining this new name, but this is what we're talking about today, PrAKI. And again, I'm not the expert, because I think most of the people on this call have had far more experience than me in looking after women with PrAKI, but I'm really, really passionate about changing the journey for these women and raising awareness that this isn't a benign condition. It isn't something that just goes away and has profound impact on the individual, their families, their babies, and their long-term health. But one of the first things I kind of want to share, if I can get my screen to change, those are my disclosures, is that how incredible the kidneys are in pregnancy. And I often describe to colleagues that the best treatment for chronic kidney disease is a pregnancy, because there's this magnificent increase in renal blood flow, which increases GFR without causing hyperfiltration damage. So somehow the kidneys are extraordinarily clever in pregnancy, and they're able to augment the afferent arteriolar arteriolar vasodilatation. Sorry for everybody that's not a renal physiologist on the call, and simultaneously the efferent arteriole. So we get this lovely increase in blood flow, increase in filtration, and alongside with that, there are lots of changes in kidney tubular function which accommodate this increase in blood flow. So most people who become pregnant have a fall in their serum creatinine and an increase in GFR up to 50%. And as a consequence of that increase in blood flow, the kidneys grow up to 1 centimetre in length. There's also dilatation of the collecting system. And so we often see hydronephrosis in pregnancy, particularly on the right. Now, that potentially is something to do with the progesterone dilating the renal tract, and due to the position of the uterus, which starts to dextro-rotate, so rotate round to the right, and causes a sort of a slight mild functional obstruction. But one of the other amazing things that the kidneys do in pregnancy is they contribute substantially to plasma volume expansion. So we know that there's an increase in plasma volume during pregnancy, and we see that a lot of some of the electrolytes fall, but also women become more apparently anemic because there's more kind of water. But this is quite an important phenomenon which we think potentially could contribute to future placental perfusion. And I'm going to come back to that a little bit later, which is kind of really setting the scene for why we need to prevent kidney damage to ensure that that plasma volume expansion happens in subsequent pregnancies. So unfortunately, the literature about PrAKI is fairly sparse, and it's very heterogeneous. So there are various different systematic reviews that have been collated looking at pregnancy outcomes for the mother and for the baby and for the kidneys. And unfortunately, the comparison cohorts are very variable. Either it's other women on an intensive care unit or healthy pregnant women. But I think really the general message is it's bad. There's definitely a significant increased risk of maternal death, stillbirth. Babies are likely to be born earlier and of lower birth weight. It's obviously a bit of chicken and egg, because it may be that there's a pregnancy complication that leads to those complications, and then the AKI is consequent. But regardless, I think we need to raise awareness that if an AKI is happening, it's likely that there are other bad things happening as well. These are old data, but really sort of to highlight the concern that we have in terms of the disproportionate burden of AKI in low-income settings. So this is a population cohort pulled from routinely collected data in Canada, suggesting that the number of women who end up requiring dialysis during pregnancy is 1 in 10,000 deliveries. So it's extremely rare. Usually in my hospital, we deliver about 7,000 women per year, and there's about 2 women per year. And this is a high burden, high risk maternity hospital. Whereas I know that in some of the sub-Saharan African countries that we have the fortune to work with, that there are even dialysis facilities in the obstetric high dependency unit, because there's such a high burden of disease. And the causes for that, I think, are multifactorial, and we need to understand more. But this is, I'm just wanting to highlight that another study, a systematic review of community AKI in pregnancy, led to 1 in 1,000 individuals requiring hemodialysis. So again, I'm just highlighting the experts on the call and the number of pregnancies or postpartum women that you've needed to dialyse compared to us in London. The major causes, though, are very comparable across different resource settings. So preeclampsia seems to be a real risk factor, vulnerability for the kidneys. Sepsis, unsurprisingly, is a cause of AKI, and hemorrhage, obstetric hemorrhage, predominantly postpartum, and the combination of preeclampsia and hemorrhage, you can imagine, is multifactorial, and these women are at very high risk of developing acute kidney injury. Data internationally in high income cohorts also suggests that the rate of acute kidney injury, various definitions, but is also rising. And that appears to be mediated by women who are delaying pregnancy, so potentially higher vulnerability of complications, multifetal pregnancies due to assisted conception, and there are more women with chronic kidney disease that are being supported to have pregnancies. But the highest risk group are those with hypertensive disorders of pregnancy. And again, this is a sort of a category that we really need to keep an eye on and understand more about how to prevent PrAKI in these settings. So there are lots of causes of PrAKI. And again, going back to medical school, we still tend to define them according to the pre-renal, renal and post-renal causes. But the reality is that many women have several of them going on at the same time. And really, again, it's sort of layering of these insults that causes the damage. These are some examples of the different causes. Early pregnancy tends to be associated with hypovolemic causes or sepsis, and then the postpartum causes, bleeding again. In the UK, the routinely delivered pain relief are non-steroidal, so diclofenac or ibuprofen. And there's more recently been a push to try to highlight the women that are at risk of an AKI to try and avoid those agents in that setting. And obviously pain relief is really important in that setting, but again, kind of thinking about the wider picture, if someone's got a rising creatinine and layering in some diclofenac or ibuprofen could be the thing that tips the woman over the edge. One thing that I'm very careful about when I speak to obstetricians is that when somebody becomes anuric, as nephrologists, we shouldn't immediately accuse the obstetricians of damaging the ureteric tract. Obviously, that can happen, but in my experience, it is relatively rare. And obviously, we need to keep our obstetric friends on board whilst we're kind of helping them to learn and understand PrAKI as well. I think this is a useful fact for obstetricians. They obviously are very concerned about postpartum hemorrhage, and that's due to the magnitude of blood that enters the placenta every minute. But the kidneys have even more blood flowing through the kidney, and this is per minute, and this is in the non-pregnant setting. So imagine in the pregnant setting, there are litres going through. And those of us that do kidney biopsies know how rapidly that they can bleed. But I think it just highlights the importance of the kidney as a vascular organ and the enormous demand and the cardiac output contribution. So you can see why, if there is a reduction in blood pressure or there's any blood loss, that the kidneys are very easily compromised. This is a slide that is relatively old now, but keeps being repurposed, and I hope that one day someone will be able to come up with a better kind of differential at different gestational time points. But I still think, unfortunately, the reality is that these insults can happen at any point in the pregnancy. I think one thing that everybody gets very excited about in the nephrology world is whether or not there's a complement-mediated disorder, or whether or not a woman has a TMA due to TTPs, so ADAMTS13 deficiency. I think the only useful thing that I can really say in this setting is that TTP, so the ADAMTS deficiency AKI, tends to happen earlier in pregnancy, and the complement dysregulation happens later, usually after delivery, and that potentially is due to the delivery of the placenta, which is very good at dampening down complement activation. But otherwise, most of these things can happen at any time, unfortunately. So one of the kind of key concerns from a nephrology perspective is the fear of kind of missing this atypical HUS or these serious causes of thrombotic microangiopathy. And one of the things that we kind of obviously need to do is work through the list of differentials. And I appreciate that in some settings, some of these diagnostics are not available. But the reality is that most women who have a TMA in pregnancy have preeclampsia or HELLP syndrome. But we're starting to kind of unpack different characteristics of the diagnostics that potentially give us a clue as to whether or not somebody's behaving differently, whether or not they've had a postpartum hemorrhage and that's led to platelet loss and a low hemoglobin that looks perhaps different from a preeclampsia or a thrombotic a TMA that's driven by complement dysregulation. So this is this horrific algorithm which we're hoping to kind of refine in the future. And I don't recommend that anybody currently uses it. But my rule of thumb at the moment is that if the platelets and the hemoglobin aren't starting to recover 2 days after delivery, then we need to look harder for something else that's driving it. If it's a preeclampsia or HELP-driven picture of acute kidney injury, thankfully, delivery and the removal of the diseased placenta tends to start to improve things quickly. But why pregnancy? Why TMA? What's going on? Why do people start to get this sort of nasty acute kidney injury picture with this thrombotic microangiopathy? As I said earlier, there's lots of complement activation in pregnancy, and when the placenta is delivered, then that kind of causes more endothelial activation. We've also got this angiogenic imbalance, so potentially low placental growth factor, which calms down the endothelium, and the high soluble FLIT driven by a diseased placenta. And then bleeding can obviously kind of contribute to this TMA and this AKI picture. So it's kind of this perfect storm of horrible things happening where these women are in the centre of it, who've previously potentially been fit and well, but these insults lead to potentially quite severe AKI. This is a French cohort that attempted to try to work out how to predict those women who've got more severe kidney disease and more complex causes of a TMA. I just wanted to highlight to you, there's a lot of these women who had a final diagnosis of a TMA along the bottom there, that the majority were thought to have preeclampsia on arrival. And that's probably true, in all honesty, that preeclampsia can also trigger these more complicated thrombotic microangiopathies. But I think the message is to kind of watch all these women very closely, and the majority do recover, but those that don't, we need to kind of look more closely with more complex diagnostics. One of my learnings from this study, though, was around the kind of increasing incidence of cortical necrosis, and that seems to be happening more frequently, potentially with the use of tranexamic acid, which now obstetricians are using routinely in obstetric hemorrhage. And I'd be interested to hear from others about whether or not they feel that they're seeing this more commonly. Why cortical necrosis is more common in pregnancy, we still don't really understand, and it may be a consequence of this increased renal blood flow due to direct shunting and this afferent and efferent arteriolar dilatation, which is suddenly shut down and can't auto-regulate. But again, something that needs to be explored, and if we can understand why, then there may be opportunities to prevent cortical necrosis, which is obviously a very horrible and dangerous situation. So other things that we can do to diagnose the cause of acute kidney injury in pregnancy, it's hard, and obviously particularly if there aren't any diagnostics available, and there are discussions about the safety, if you can do a renal biopsy in pregnancy, whether or not it's the right thing to do. And I rarely do them in pregnancy, although we can, they're readily available, unfortunately for us, but usually there isn't an indication to do so because it's towards the end of the pregnancy, and usually the best thing to do is to deliver the woman. The other challenge about doing kidney biopsies is around this massive increase in renal blood flow, and we're obviously concerned about women bleeding as a result of a kidney biopsy. And the most tricky time to do a kidney biopsy is the time when you really want to do a kidney biopsy, which is around that sort of mid-trimester, when you don't want to deliver the woman yet, but yet she appears to be at one of the highest risks of bleeding. So unfortunately, a kidney biopsy is not the best tool, but it can be considered if you're early on and there's a woman with nephrotic syndrome, for example, and it's helping you decide on treatment pathways. Another challenge in terms of identifying acute kidney injury in pregnancy is to do with interpreting serum creatinine in pregnancy. And we do know, because of this increased renal blood flow, that creatinine does fall, as I mentioned earlier. But the challenge is really interpreting the rate of change towards the end of pregnancy that indicates that there's harm rather than just normal physiological change. And this beautifully shows the natural change in pregnancy in serum creatinine. But these data were from women who had an indication to have a creatinine done in the first place. So they're not truly normal, healthy kidneys as far as we know. And Katherine is currently working on some new centiles that are even lower than this, that suggest that if you've got a creatinine above 77, that is an indicator of kidney damage. But again, we're kind of working on this and looking to see whether or not we can interpret the change in the centiles, like the obstetricians do with fetal growth, to track to see if you stay on your line, if you like, and whether or not how far you need to go off your line, which is associated with kidney damage. So watch this space. Sadly, very few people have looked into this, and probably understandably, very few countries have a creatinine as a baseline performed in pregnancy, because probably for the majority it's not relevant, but we do, or not needed. But it would be very helpful, I think, to kind of understand how to interpret a creatinine when we don't have a previous creatinine. So Katherine's going to be speaking shortly, but we kind of feel that actually urine output may be a very important indicator in pregnancy. And again, you people that are working kind of at the front line have got a lot more experience, and I'd be again interested to hear about thoughts about whether or not anuria or oliguria is going to be an even better signal. Obviously, there are loads of different biomarkers that the whole renal world has been sort of searching and exploring for ages, and yet none of them have really rolled out into routine clinical care at all, mainly due to expense probably, but also due to test performance. And certainly, even the best markers that everybody is keen to have, like cystatin, for example, has not been shown to be helpful in pregnancy, and often these markers behave differently. So I think it's really important in the future, before we adopt anything new, that we check that it actually formally works in a pregnant woman. We have looked in our cohort at King's, again, kind of much lower rates in other parts of the world, to really understand what a change in creatinine triggers an AKI, but also what the causes are and what the responses are from our clinicians. We looked at a large number of deliveries and found that most women were scoring as a stage 1 AKI, which is a 50% increase or a rise in greater than 26 micromoles of creatinine. And I guess that's surprising. You'd expect most of them to be sort of milder cases. Most were at delivery or after delivery. Very few were in the antenatal setting. But interestingly, a proportion actually didn't have any precipitating event. And I do wonder whether or not some of these women have kind of met these thresholds when actually it's just a physiological rise in creatinine. The major causes, though, are the same old story. It's hypertension, which seems to be causing that vulnerability to acute kidney injury, either with additional insults or alone if it's very severe. Just wanting to highlight again this major concern that I have, that the incidence of acute kidney injury in different settings is very different. And this latest systematic review suggests that it's 30 times higher in low middle income countries. And whether or not that's due to obstetric care being more challenging, people being in a more remote setting, referral pathways being more challenging to coordinate, and resources, or whether or not there is also an intrinsic vulnerability that is potentially related to these settings where there is a very high burden of preeclampsia that could be driving this. But it'd be wonderful to kind of understand better so that we can do more to reduce these rates. Just wanted to show you again a different two studies, cohort studies, that are looking at the causes of acute kidney injury in low middle income settings. Relatively small numbers, but again, you can see that eclampsia, preeclampsia are really kind of driving these rates, and it's relatively few that are kind of affected by hemorrhage and sepsis. So this blood pressure and monitoring these women with high blood pressure is going to be key. The nephrology world is starting to wake up and realise that this is potentially a key driver, not only of burden of disease at the time of delivery, but then also in later life for women. There are higher rates of CKD in women, particularly in low middle income countries. And I do wonder whether or not having multiple obstetric challenges with repeated PrAKI is contributing to this. And there's a recommendation from the International Society of Nephrology that women shouldn't be dying of PrAKI and having the long-term complications. But obviously it is very multifactorial, and there are lots of factors that are kind of contributing to this increased risk that are not all fixable by good obstetric care. I wanted to briefly touch upon a study that we did a few years ago now, but it was something that really led to opening the eyes of the obstetricians that I work with. We at that stage, I managed to persuade them just to record how many women had a creatinine greater than 90 in this cohort study in South Africa, and they were astounded to find that this was the best predictor of maternal death, 6-fold higher if you had a creatinine greater than 90. And I think as nephrologists wouldn't be surprised by that. But I think one thing was surprising, that nearly 20% of the women with preeclampsia had this very high creatinine. And I know it doesn't feel very high to us as nephrologists when we're dealing with the 900s or even 2000s, but actually this is clinically meaningful in these women that have very low creatinines. So this led to a really exciting piece of work that we're in the process of publishing at the moment, which was actually using point of care creatinine in a cohort in Sierra Leone. And we trained our midwives on the ward, and we taught them to identify women at high risk of developing a PrAKI. And we did that by selecting women who either had very high blood pressure or very low blood pressure, using this simple blood pressure device called the cradle device. And it gave an arrow up for too high blood pressure or an arrow down for too low blood pressure. This was how we selected women to take part in the study. And we attempted to do serial creatinines so that we could detect a change in kidney function to identify those who had a PrAKI after 24 hours. And so those results are currently being analysed, but I have to say that I am completely sold on point of care creatinine as a really useful tool to be able to identify PrAKI in an early setting. And because you don't have to wait 24 or more hours for these results to come through, it takes literally 30 seconds on a tiny finger prick of blood, so you can do several tests in an individual and immediately respond to those findings. And this is a lovely story who a lady who wasn't having blood tests done at all, who was extremely sick with severe preeclampsia, and who had a creatinine of 500, which was detected by the point of care test. She was transferred to the dialysis facility, had 3 sessions of dialysis, and now is extremely well. Interestingly, she's subsequently been found to have a single kidney, which has potentially contributed to this AKI, but she's well, considering another pregnancy, and has a gorgeous, gorgeous baby boy. So a really exciting and wonderful outcome because of that point of care test. Just kind of coming on to this concept, which I kind of have to emphasize more to obstetricians, about the fact that a rise in creatinine doesn't mean that it just comes back down again and everything is okay. And we're increasingly recognizing that that injury does long-term harm. In our cohort at King's, we identified, you can see here, the kind of, a lot of people didn't have creatinine testing after delivery, after their AKI, particularly those with milder disease, but a high proportion of those that had repeat testing, actually their kidney function hadn't resolved, and they'd already got evolving AKD or acute kidney disease or even CKD. And again, similar numbers or even higher numbers in our South African cohort. Again, very few women had follow-up testing, but a lot of them had evolving chronic kidney disease. We looked at a cohort, a larger cohort at King's College Hospital, and found that 70% of women who'd had a hypertensive pregnancy had some sort of renal dysfunction, and this was at 6 weeks after delivery. A proportion of those still had residual proteinuria, which again potentially could indicate ongoing renal dysfunction, and a reasonable proportion also had a reduced GFR. So I think that this isn't going to go away. I think that these are women resource allowing, should be followed up and at least prepared for a future pregnancy. And the reason for that being that this really interesting study that was done in Boston, they looked at women who'd had a previous AKI. So whether or not that was related to pregnancy or not, it didn't matter. They identified women who'd had a nasty AKI. Oh, I seem to have flipped to another screen. Sorry about that. Where that's gone. I'm going to stop sharing and come back. Sorry, I'll keep talking. But they had they had looked at women who'd had an AKI and then looked at their pregnancy outcome. And they found that women who'd had an AKI, despite completely normal kidney function entering pregnancy, had worse pregnancy outcomes. And the worst pregnancy outcomes were actually driven by preeclampsia. So they had smaller babies, they had earlier deliveries, and they had much higher rates of preeclampsia. Again, just spelling out that these are women who had apparently normal kidney function. So the hypothesis is that women who have had a previous AKI have lost some renal reserve. They're less able to adapt in early pregnancy and to increase that plasma volume expansion, which is important to sustain pregnancy and enhance that placental perfusion later on in pregnancy. So I think that if women don't have had previous kidney injury, they've got reduced renal reserve and they're unable to expand their plasma volume, they have reduced cardiac output, and that could contribute to preeclampsia. And this has also been shown in a brilliant animal model that confirms that hypothesis. So I think there is this vicious cycle that we're kind of understanding more and more about. We have women who've had a PrAKI, an acute kidney injury, that go on to develop kind of a subclinical chronic kidney disease. Potentially that evolves with more insults, but then in the next pregnancy they get preeclampsia and another PrAKI event, an acute kidney injury, and this eventually kind of downward spirals to more progressive chronic kidney disease and potentially ending up with end stage. We know that there's a strong association between preeclampsia and end stage kidney disease, and this may be one of the mechanisms. So finally, I just wanted to highlight the horror for the patient in the middle of this, and that obviously a woman that has hopefully, going to have a new baby and expanding their family or starting a family, and it's a really exciting time. But then these catastrophic events happen, and there are a lot of women who we have talked to after their pregnancies who describe how traumatic this experience has been, ending up on dialysis during a pregnancy if it's available, and the fear for their lives, the burden and the concern to their families of having to potentially pay for additional resource, and the uncertainty about the outcome for both them and their baby. So obviously in the middle of trying to kind of save the kidneys and save the woman, we need to remember the person and their family in there so that we're able to give that emotional support as well as the physical support. So just to wrap up, I hope I've highlighted that PrAKI is a relatively rare event, but it's becoming more and more common, certainly in high-income countries. But in low-income countries, you are the experts, you have the knowledge, and we have an opportunity to drive change. I think we need to work harder on improving our diagnostics, being able to interpret kidney function in pregnancy, potentially using point of care approaches and or better, closer urine output monitoring. We need to make sure that anything new is tested in pregnancy before translating and rolled out into clinical use. And we need to really understand exactly who is at highest risk of having long-term kidney damage so that we can educate obstetric colleagues to understand the importance of protecting the kidneys. But hopefully, I really genuinely believe that there's an opportunity to really drive change if we're able to kind of educate people, help them to understand that this is an important change that we can't just ignore, someone stopping passing urine, and then hopefully will make a big difference for the women, for them in their current pregnancy, but also in their future pregnancies and their future long-term kidney and cardiovascular health. So thank you so much for listening. Thank you to all the team that I currently work with and all the team that I hope to work with in the future. And I'm really happy to take any questions. Thank you.
Thank you, Dr. Kate. Quite an enlightening presentation there. So far, I don't think we have any questions in the Q&A chat box. But I think, well said, I think at the end, PrAKI needs to have a bit more attention. I think in terms of also for it to attract funding. Because I think it's something that really falls through the cracks when you look at the focus, even if you look at international aid coming into into low-income countries or sub-Saharan Africa or whatever government programs focus on. I think most of the vertical programs focus on HIV, TB, malaria, and then we forget that we have this critical marker of health system failure in maternal health, which is now PrAKI. So I think it is a call to action to all of us to make as much noise as possible, to also push out so that we can get, data. We can collect data on this. I think a lot of research needs to be done. And that will also allow even the people who sit or the policymakers to also think about PrAKI and also give a bit more investment there. But thank you for that. I think it's quite enlightening indeed.
I can see that question. I don't know.
Mm-hmm.
And I think that's something that Katherine is working on at the moment, but we would love for other people to share their thoughts and potentially to help us see if we can get a bigger data set to really understand exactly what levels are clinically meaningful. I'm just putting my email in the chat, and please do reach out and contact me if you are interested in kind of contributing or collaborating in this field, because that I think Manu has put the most important question there. Thank you.
Thank you. I think the email is on the chat box. You can shoot your questions over to Dr. Kate. I think in the meantime, we can move over to the second presenter, Katherine Clark. Over to you.
Thank you so much, and what a honour it is to be here, and thank you so much for hanging around to listen. So following on very, very nicely from what Dr. Yuri was saying just then about the call to action, and I think the work that we've been doing through the Global PrAKI Consortium and the work that we'd love to continue to do with you guys as much as possible is trying to facilitate a lot of what you've just suggested. So just over the next 10 minutes or so, I was just going to share what we've done so far and then what our plans are going forward to try and work together on a global scale to uniform action at individual practitioner level, but also at that sort of policy level and service development. So I will share some slides here. So I won't hang around on this. Kate's just given such a clear overview of why this is something we need to be talking about, so I don't think I need to hang around. But the one thing that I will suggest is the really important role of nurses and midwives in the identification and prediction and therefore prevention of PrAKI. A lot of the cases, as we've been discussing, are avoidable by early detection of risk and good fluid management, good appreciation of changes in blood pressure that might warrant treatment, early identification of changes that increase the risk for bleeding and sepsis. And a lot of that is done by midwives and nurses or people working in those more peripheral healthcare units. And so having systems that allow us to perform those early antenatal checks appropriately, and then also that good early intrapartum care appropriately and as meaningfully as possible, using things like point of care testing and validated blood pressure devices, as well as our clinical knowledge, midwives and nurses really are placed in a really strong position to have a big impact. So this truly is a multidisciplinary conversation. But the reasons that we ended up developing the consortium, and the sort of 4 founding members were indeed Kate Bramham and I, as well as Rasha Shamiz, who I think is on the call actually, who's a nephrologist, a professor from Egypt, and also Dr. Kenneth Chandra, who's an obstetrician from Lusaka in Zambia. So the 4 of us worked together to establish the consortium, and this slide aims to summarize our sort of thoughts and the need for the consortium. And the first was what we've clearly described, which is this lack of validated definition, and that obviously makes gathering homogeneous data sets and therefore drawing strong conclusions challenging. The second is this lack of acknowledgement that PrAKI does matter, as we've also described. And it matters, yes, at a policy level, but it also matters at a clinical level. So when we're describing someone with preeclampsia, do they have preeclampsia with a PrAKI or preeclampsia without a PrAKI? Because we know that their outcomes are different. And then this lack of training of midwives, and it's certainly true in the UK, and we're learning it's true around the world, that actually our training on fluid management, particularly in systems where midwives aren't nurses first, is minimal. And so to be able to do that well is actually quite challenging, particularly with a PrAKI focus. So acknowledging these three big challenges, there were also 3 reasons why now was the right time, or earlier in 2025 was the right time to set up the consortium. And the first was that the nephrologists community was acknowledging PrAKI as a problem and something that really warranted time and effort and investment. So indeed there was an ADKI meeting, an acute disease quality improvement meeting, hosted in Hyderabad in India last year, focused entirely on pregnancy acute kidney injury. The ISN have developed their Train the Trainer program with a group of nephrologists from around the world, including work on PrAKI. There's also other networks. So for example, India have a consortium of PrAKI that's starting to do really good work, and certainly in other countries there's good things going on. And also at a policy level, there's a real focus on improving midwifery education and midwifery models of care. So there's this real movement happening now in silos, that if we had a way to bring everyone together, then we can hopefully make big changes. So that was sort of the rationale. And that when we tried to describe our aim, this is what we came up with. So the aims of the consortium is to become an established global network who work collaboratively to improve the prevention, identification and management of PrAKI, and we'll do that through research and education. So this was our plan of work. We started by doing a survey in spring or May time this year to look at the barriers to identification and management of PrAKI, and thank you to those of you here who contributed to that. We then had our launch event in July, which was a great meeting of the founding members of the consortium in Kenya. And then we've got plans going forward, which I'll come back to in just a minute. The survey, I just wanted to share a little bit. We had such good engagement from around the world. So we had responses from 79 countries, which is about 1/3 of the world. And actually the map looks great, but then unfortunately we didn't do a very good job, despite a lot of effort, to get responses from low-income countries. And I think now we're much better placed to perhaps look at repeating this survey and trying to really enhance the number of responses from the places where we really do have the experts in PrAKI, because unfortunately that's where the biggest burden of disease was. But just to share some of the results, which we haven't quite published yet, this is a heat map. So green is good and red is bad. And these were some of the challenges that people had around getting serum creatinine results. And there's clear patterns here that are based on things that are resource intensive. So we need to be thinking about how to work on that. And then, of course, this won't be news to people on this call, but there was obviously big challenges around the availability of renal replacement therapies and interventions that really are life-saving. So we do need to focus on prevention as much as possible, so that those resources are saved for those that really do need them. The other thing that we found out from the survey is that this fluid management piece isn't easy. So we asked people to send in photos of the vessels that they were using to measure urine output, and it really is challenging in lots of environments. And these were, those cut-off water bottles were by far the most common vessels people were using. Interestingly, all these photos were sent in on smartphones. So we need to think about what is available in the clinical area versus what is not when we're thinking about potential solutions. So we've had our launch event, which I just wanted to share a little bit about. So this was, we had 48 of our founding members representing 20 countries, and the meeting was endorsed by the ISN, supported by FIGO and the International Confederation of Midwives, and we had a big group of different professionals represented. And it was a very focused and working meeting, so we really tried hard to deliver outputs. And the main output was the need for a toolkit. And that toolkit is a set of resources that focus on clinical change, policy interventions, and then education. And so we're going to be working in working groups, and we've started work on some of these already, including designing a core outcome set, both for clinical data collection and for research data collection, as well as some curriculum guidance, patient tools, management flowcharts, etc. So this is all going to be available for free on our PrAKI website. We're working hard to make it easy to practice in an evidence-based way for the evidence that we do have. So we're just getting a statement together to suggest that this cutoff of 77 micromoles per litre is indeed what we should be using for pregnant women, and plan to disseminate this really widely. So we'll be asking you guys to help us by disseminating this. We will also be disseminating tools that can be used in clinical settings to help uniform our approach to the management of pregnancy AKI, and keeping it as simple as possible. We've also had a few other little events, a few other sideline events happening. So some of our members have been giving talks around the world in different forums. We had a stand at the FIGO, the Obs and Gynae International Conference, where we got a lot of interest. And we have plans to move forward with a global snapshot. So similar to that which the ISN did on AKI a few years ago as part of 0 by 25, we hope to do a snapshot in spring next year. So we'd love for you guys to engage to help us with data collection. And we aim to disseminate or distribute point of care devices to centres who are able to participate but don't have good access to creatinine testing to enable participation. So we've got good plans for research going forward, and once we've developed our core outcome set, hopefully that will enable us to be more homogeneous in how we're collecting these data, and indeed that hopefully will improve the quality of the snapshot too. We are working in the side on projects to try and facilitate some of these best practices, using smartphones to assess urine output, for example, taking photos of urine in whatever vessel, so your phone can calculate for you what the fluid balance is and give you indications of how best to respond. I will, as a call to action today, I will ask anyone who feels able to scan this QR code and make a pledge that you will go to your place of work and check if you have a mention of pregnancy AKI in your guidelines or in your SOPs, or indeed as part of your regular training, and make a pledge to try and change that if indeed it's not there. All of this stuff is available on our website, and that's the QR code for our website there. But please do get in touch, and thank you so much to everyone in the consortium for all their hard work, and also our collaborators who've made the consortium first half a year so productive.
Oh, thank you, Katherine. I think that's really good work that you're doing out there.
Thank you.
And thank you for taking us through that. I just have a few curiosity questions myself. Wondering just out loud, because we do have pregnant women in villages that are not able to probably access care in terms of, because I've seen you're targeting obstetricians and also, I believe, traditional birth attendants, if I'm not mistaken.
Absolutely.
My question is is there a way to utilize the community health workers in a way that they can also identify at-risk pregnancies, probably patients who might develop preeclampsia or sepsis, and probably what kind of training or equipment would be effective in their role? Because I think it will be essential that this is pushed beyond the hospital walls, so that, because we know PrAKI is preventable, and there are ladies who will probably, or pregnant women who will just access care during delivery and might probably miss, is it called antenatal? Yes, antenatal checks. So is it possible to also include community healthcare workers?
Thank you so much, and absolutely, we're very aware that that's a big missing piece, and something that we need to work hard to try and address. Of course, it's not an easy thing to do, but working with people who do spend time doing outreach work and working with those community health workers is something that we're very keen to do. So again, another reason to reach out to us, please, if you've got any ways to help us develop training materials in a way that is usable for these key people in our ability to make a change.
Thank you. I think that will be, it's something that, as you said, working as a team, and I think also including more people, especially in the rural areas. I'm sure you should be able to make more impact, but thank you for that. I think there's a question, the box from Dr. Amar. I think his question is on, I think, to Dr. Kate. Is asking, in a patient who's developing a prerenal AKI, what are the most practical clinical steps you use to decide when the kidney is still fluid responsive versus when the further fluids may start causing harm? Yeah.
And
I hope that
that's
makes
a
sense.
brilliant question, and I suspect that you know better than me. But I think that we need to shift away from this obstetrician approach whereby they set a standard rate of fluids per hour and move to our kidney world where we give boluses of fluid. And they, as yet, are not kind of familiar with that. I suppose one of the challenges is in women who've got preeclampsia, potentially obviously have leaky blood vessels and also potentially have some left ventricular dysfunction. So we may precipitate pulmonary edema, but I think that if we're giving small boluses and assessing response, I think that that is the best approach. And obviously assessing the kind of clinical fluid status of the individual in terms of their respiratory requirements and obviously attempting to sort of assess JVP. One of the things that we're exploring and really keen, if anybody has got any experience in this, is looking at using point of care ultrasound to assess fluid balance in pregnant women. It's kind of increasingly used in intensive care settings, and I think it potentially is obviously recognizing that it's expensive to get the first to purchase the device, but there are devices that are getting cheaper and cheaper that you can use with a smartphone. So potentially using that to assess a woman's lungs to see whether or not she's got any pulmonary edema already, and then bolusing at that point. There are also some techniques that the intensivists are using in Cape Town to assess if you do a straight leg raise and look at the increase in cardiac output as a result of that kind of internal fluid bolus, if you like, so you're not doing any harm. So I think that there are going to be new and better ways that we can practically assess, but at the moment I would suggest giving a bolus rather than sticking someone on 80 mils of fluid per hour for 2 days or whatever they do. No offense to any obstetricians on the call, but time to change.
Right. Good one. Time to change. Yeah. Another question, I think, from a participant by the name Manu. This question is, what's your opinion on early versus late initiation of dialysis in PrAKI, especially for preeclampsia patients? Does it help to wait?
I honestly don't know the answer to that, and I think that we need to have some big data sets with your help to be able to understand whether or not there's any role for dialysis in terms of accelerating recovery in that setting, or whether or not actually, you know, hanging on in there and only using it for the sort of routine indications that we use outside of pregnancy. I can't I kind of, yeah, my instinct is not to use it early, but again, I'm sure that you've got better insight than I have. I don't know, and would love to know your thoughts, actually.
I'm saying thank you for the presentation. I was just saying we handled a patient recently who I think was a patient who was managing for preeclampsia, then later on postpartum, like a week later, started having a lot of edema, facial puffiness, and lower limb edema. And even on labs with the creatinine were rising. And our initial thought was just to wait and try and do like a fluid, diuresis with furosemide and just see the response. Unfortunately, we ended up doing the dialysis just as a final management plan. But I just wanted to know your thoughts on that, because now I was thinking maybe the waiting was harmful, especially now we're being informed that AKI is just not a disease that comes and goes. It leaves your kidneys worse than it found them. So I was just thinking, does it improve to do it a bit earlier than waiting, just doing the diuresis and waiting? Yeah, thank you.
In the non-pregnancy setting, the big intensive care trials haven't shown any benefit between starting early or waiting. And I think other than obviously sort of mortality, but in terms of kind of accelerating renal recovery, I don't think there is any benefit. But I think that our pregnant women may be a bit different from your general kind of intensive care population, because it's very rare that you've got somebody with high blood pressure that's got an acute kidney injury in an intensive care setting. So just sort of thinking out loud, I wonder whether or not these women are less vulnerable to any volume related damage in the same way that a kind of a septic person would be. So if you've got preeclampsia and hypertensive kidney injury, then maybe you tolerate dialysis a bit better. I really don't know, but it'd be so interesting to look to see. I'm kind of really keen to work with Africa Health Network to see whether or not we can look at the women who have had dialysis through your networks and see what happens to them, and look at the different causes and see whether or not, whether or not you have fewer dialysis sessions if you're a preeclamptic and you start at lower levels of lower thresholds. I don't know, but I think it's a really important question, and I think we've got the data to be able to answer the question if we just pool resources. There's a project for you, Manu.
Yeah, thank you.
Yeah, thank you for that reaction. I think for most cases, of course, we do individualized care. I think for Manu's case, I'm sure you're feeling bad because you waited, but sometimes things are not that clear. What I think, according to my opinion, I think it would be good for sometimes, even as you're trying conservative management, you try and just trend the UECs, probably look at the renal function. If it's not improving, you don't wait too long. You look for any other form of renal replacement therapy if needed, and you go in. Yeah, but I stand to be corrected. Thank you. I don't know whether there's any role, Dr. Kate, for, I think when you walk into an antenatal clinic, there's usually, I think, urine dipstick that is usually done quite a bit. Sometimes you have a lot of false positives with that, because in pregnancy, a lot of things happen. There are UTIs here and there. There's proteinuria. Sometimes you're not really sure. And then you also have this cohort of patients that, the ones with, what is it called? The ones with a lot of nausea. So they get, sometimes they're vomiting, they're dehydrated. So they also have probably reduced urine output because of intake. I think that can also be a challenge. So I don't know whether there's any role for, of course, the urine dipsticks that we do before you consider probably a patient or other tests, because sometimes it's expensive and they're not able to do UECs. I think nowadays we're looking at cystatin C instead of even using creatinine, which is not accessible. So in terms of screening tools, apart from, of course, urine output, looking at also blood pressure, of course, clinical signs and symptoms, are there any other things that can lead you to probably narrow down your diagnosis, kind of, that is less costly, if I can put it that way?
Yeah, I would love to give you a whole range of solutions there, but as yet, I don't think there are any. I think, I don't know whether or not, and again, I don't know the answer to this, but I don't know whether or not you use the 10 strip dip or whether or not you just dip for protein. But certainly a colleague has recently re-educated me on specific gravity in the urine and using that as a tool to determine whether or not somebody is dehydrated. And so that could potentially be something that we could introduce, but it may be just be easier just to look at the colour of the urine. And obviously if it's concentrated, that could be something that could raise alarm bells. I'm really optimistic that there will be a transformation in the space of point of care testing that will become, that the technologies and the bioengineering are now really radically changing, that we'll be able to develop some really cheap diagnostics that really change, transform this space. But at the moment, sadly, I don't have any immediate solutions for you other than your brilliant clinical acumen and gut instinct.
Sure. Yeah, I think as you mentioned, we sometimes go back to the basics. I think for like I'd mentioned, patients with hyperemesis, gravidarum, vomiting, you just need to do like a diagnosis by exclusion, and then maybe you narrow down to something. Especially in a low resource setting. So I believe we can end the session. So I want to just give a vote of thanks to Dr. Kate Bramham and Katherine Clark. I think you are really pushing on PrAKI and raising awareness, and it's really good to see what the consortium, activities in terms of the traction that we are having. I think this will create more awareness, and it will create the sufficient chatter and noise for the policymakers also to put a lot of focus on this. And hopefully, as Dr. Kate has mentioned, as we continue to collect more data, we'll also just build on to what we already know. And again, that will also help inform policy, even as we do more research. So thank you, Dr. Kate, and thank you, Dr. Katherine, for taking your time to take us through these enlightening topics. And on behalf of Africa Healthcare Network and our panelists, we wish that you will also come back again another time as you give us more developments on what you're doing, especially on the growth and as you're pushing the needle. Thank you so much, and wish you a good evening.
Thank you so much, everyone.
Thank
Good
you so
evening.
much.
Bye-bye.